I think we need to gather more data and more experience. Let's assume that study data would suggest that it is better for the quality of life and also for the outcome to do more than one procedure, more than one valve procedure in one setting. Then this would become more frequent, but it has to be a high volume center with lots of experience in all of these different disciplines. And then it could be more prevalent and more frequent one day, but nowadays it is the exception. We have learned from epidemiology, first, tricuspid regurgitation is frequent. Secondly, tricuspid regurgitation is associated with poor outcome and severe heart failure symptoms. And third, that the treatment regimen available to date are not sufficient at all. What do we have? We have medical treatment and also surgery, but surgery usually has a very high risk for this type of patient. And therefore, to get to know all this data was very exciting for us during the last decades. And then to be able to treat this tricuspid regurgitation with catheter-based approaches with a low risk and a low intensity for the patient being able to get up out of the bed in a few hours after the procedure is of course also exciting. We need to know not only that patients are doing better in clinical terms, we need to know whether patients will benefit in terms of heart outcome data. So what we need to investigate is, do patients have an increased life expectancy, for example? Do patients have to go less frequently to the hospital for heart failure symptoms? And therefore, we need randomized trials. So randomization of a catheter-based approach in patients with tricuspid regurgitation against medical treatments. And these trials are already running, and this will be very, very important and instrumental for the whole field.